Okay, so we're going to start the next presentation, right? Please.
Bonjour, Wafa.
Okay. So the next presenter is Professor Wafa Skalli. We are very honored to have her as one of the speakers in this summer school. It's unfortunate that in the end she was not able to come in person, so she will be giving the presentation online. Wafa Skalli is one of the big names in musculo-skeletal modeling, in biomechanics, both from computational and also experimental and translational to clinics, and even work in related image analysis, like the creation of the technology behind the EOS system, which is a system that has had quite an impact, and it's used as a success story in translation. Currently, she's a professor at the RMIT Paris Tech University in Paris, and she is also the co-founder of the Skyros company that I'm sure she will introduce. So, without further ado, please, Wafa, go ahead.
Okay. So thank you for your invitation. It's a pleasure to share with you my experience on subject-specific modeling of the spine, from basic research to clinical routine for surgery planning. And I will try to show that there is not basic research on one hand and surgery planning and clinical routine on the other hand. They are connected. Sorry, I try to pass. Yes, my conflicts of interest. I'm co-inventor of the EOS system with no personal financial benefit. Royalties are rewarded for research and education. And I'm co-founder of the Skyros company with potential benefits that will be rewarded for research and education. Well, in my scientific journey, I have a long tradition of clinical collaboration with surgeons that were also inventors. Raymond Roy-Camille was the first to put screws in vertebrae, and you know now that in spine surgery it's routinely used in many countries. Dr. Cottrell and Dr. Jean Dubousset invented the Cottrell-Dubousset instrumentation, which was a revolution in adolescent idiopathic spine surgery. And so in my DNA, a strong clinical link was built from this time and was continuously developed. Also, these researchers gave me surgeons gave me the taste of research for innovation to improve the patient care, because for many researchers, this is what drives our enthusiasm and our dream. But we will see that the dream can be there, and sometimes it takes a long time to be to come true. And I began spine geometric and mechanical modeling as early as in my PhD in '93, and at that time it was not, computers were not so rapid, and the very first models were quite simplistic. But this provided in the DNA a permanent coupling between numerical and experimental approach, because with numerical approach you can give responses that can be all but clinically relevant or realistic, and so models validation is something that is essential. And as many researchers, we first considered spine modeling by approach of structural mechanics. I am mechanical engineer, and so you have to put the geometry, you have to do a mesh, introduce mechanical properties and of components, and then and control with in vitro testing that replicate the tests, and then it's okay. And once you have the model, you can simulate, for example, here a disc removal to put disc prosthesis. And it's okay providing experimental evaluation is performed. And here, for example, for this prosthesis, the experimental evaluation and the confrontation of the numerical results to the experimental results. During this phase, we can understand that, for example, when you insert the prosthesis, you can extend some ligaments which behavior is non-linear, and so you have to understand how it has been installed to be able to properly model it, and the X-ray may be very useful. But once you have the model, it's really powerful for implant design, and it is used now for various companies because it provides stress in the device, in adjacent disc, facet loads, and so on. It allows sensitivity studies, particularly related to the positioning of the implant, which is not always perfect, and we can investigate the impact of these parameters on mobility, on additional information. Here, just to give a small example, inflection, extension, lateral bending, and axial torque. We wanted to investigate the impact of implant neck location on range of motion, and we see that only in this load case you can have a change which is quite important. But this is a model built from in vitro data. It's really useful, and it can provide a real plus to the implant designer. Pushing that to clinics is not a simple thing, and it is a need. The spine disorders represent a major socioeconomic issue. Low back pain, cervical pain reach millions of persons, and is the first cause of work stoppage in France, major cause of loss of economy. And so many researchers work on spine modeling. I just did recently a PubMed search, and you have nearly 300 scientific papers a year on spine finite element modeling, on various kinds of modelings. If you go to subject-specific modeling, you have less than 10% of the publications which deal with subject specificity, because it's not simple, and we will deal with that. And if you look what is done in clinics, currently there is no current finite element-based spine model in clinical routine. And there is a need, because here you can see surgery for aging spine. You see that generally there is a large deformity. You put screws, and you connect the screws by rods, and you say, it's okay, this patient will be okay. Generally it works, but sometimes you have this situation. There is a screw pull out at the extremity, and then you have to reoperate, and again mechanical complication, and you have to reoperate, and again mechanical complication, and sometimes you finish with this instrumentation that goes from the sacrum to the basis of the head. And in complex surgery for aging spine, you have up to 40% revision rate, and of course not all of them like this extreme case, but it's a real issue. And reoperation, revision costs more than 5 billion per year in the US. And for the patients, of course, it's a catastrophe for the quality of life. So why do we have such rate of mechanical complication? The surgeon generally doesn't know. I did the same surgery as I do routinely on other patients, but for this one, it was not okay. Is it a question of implant? Very often screw and rods are used and they provide nice results on many people. Is it a question of strategy and gesture? Is it a question of patient? Generally, the complication don't occur on the very standard patient. Patients who need spine surgery are patients that have completely non-standard shape. And of course, it's a mixture of these parameters. And the surgeon has no real clues to decide how to define the strategy adapted to a given patient. I give you an example. I am currently in Spine Surgeons Congress and I participate many times to these kind of congresses. They are very humble. They share their successes and their problems. And here, for example, the case of a patient is presented. What do I do? Where do I stop the instrumentation, the screw rod system? And you see that this is a congress of expert surgeons, but there is no consensus on that point. The surgeon who operated the patient did operate him with one of the strategies. It was the complication. And so what do I do to reoperate this patient? Do I go until S1, very many options, and you have as many options as surgeons. And finally, reoperation. What do I propose to this lady? And it comes from abstention. She's very painful, she's invalidated, but you have to keep that, or other option. So you see that this is a real issue, but it is complex because it is multifactorial. One aspect which is very important is the sagittal alignment of the subject. It's a crucial issue, and you see that you have currently nearly 400 scientific publications per year. So it raises the very basic question, how do we stand? And you see that in erect position, you can have a patient which is what we call in clinical language imbalanced. And what is the phenomenon? When the spine goes forward because of aging, because of pathology, because of loss of lordosis, then the patient will try to compensate to keep the head upon the pelvis. And what are the compensation mechanisms? You have one which is natural by the pelvic that rotates around the femoral head. You have another option on the cervical lordosis that you can increase, and if nothing of that can keep the person standing, then you have what we call flexum, and you have seen people working in the street with the knee flexed, and because otherwise they drop forward. And so this is not finite element modeling. This is geometric analysis of the spine, and these observations yield the apparition of surgery planning tools, mainly based on geometric realignment. Very briefly speaking, here, for example, you have to do an osteotomy, which means cutting a vertebral bone, but you have to define the right angle, operate on one level or two levels. And this is simply as if you cut a piece of paper and restore the spine, see what you will have in a rigid body transformation. It is now used for surgery planning. It is a progress, and we have this paper that shows that there is significant reduction in the rate of mechanical failure. However, it's not always a significant progress. It's controversial because some other authors say, well, patient-specific rods did not demonstrate meaningful improvement in what we call PROMs, patient-reported outcomes. The reason, it's because mechanical phenomena require a mechanical analysis. If the spine is very stiff, then you can bend the rod, but it will deform. It's a question of balance between mechanical stiffness of the spine and mechanical stiffness of the rods. And also, it's an issue of stress in the rods. You can have rods that break, screws that breaks, and so on. So we have to go to mechanical analysis, and we need tools that are adapted to clinical routine, which means that we have to get the geometry, the material properties, and the loads from routine medical acquisition, because you have to enter into the flow of the surgeon's activity with reasonable cost, both to build the model, and it has to be semi-automatic or fully automatic, to run the simulation time has to be either real time or small enough, and provide clinically relevant biomarkers. You cannot provide hundreds of data to the surgeon and tell, look here, something could be interesting for you. And also there is an important issue, which is extensive in vivo model evaluation. And so I worked in my academic career on these various options. And I will give some examples of progress, always mixing basic research with innovation. And the first one is about the EOS system. Perhaps some of you know this system. It's a story about pluridisciplinarity and convergence. The origin, we had models based on structural mechanics. And we met Professor Jean Dubousset, which is extraordinary surgeon, and unfortunately, he passed away 1 month ago, and we pay him a tribute today at the SFCR. And he told, wow, your modeling are wonderful. Model that, please, scoliotic spine, because with the Cottrell-Dubousset instrumentation, which is a revolution, but we still have about 10% of complications. And the patients are 15 years old, so having a complication is very important. And so it was complicated for us as engineers because the scoliotic spine is particularly complex. So we asked for CT scans, millimetrically spaced and so on. And he told us, okay, this is absolutely impossible because one scan costs one X-ray dose of radiation, and so you just have to deal with a pair of X-rays, and that's all. And often when you speak with the surgeons, you have to go from their context, their needs, and what they can use in clinical routine. And so we had to find solution to get accurate enough 3D geometry from a simple pair of X-rays. And so we built a device which allowed to calibrate the environment to get 90 degrees between the two, and we found modeling solutions. I will not enter in details. And having that, Professor Dubousset told us, okay, in Saint-Vincent-de-Paul Hospital, there is a very new system, which planar system, but it lowers the dose by a factor of 10. And this is due to Sharpak, who is a Nobel Prize of Physics, to Sharpak stuff. And so the idea was to, we contacted Sharpak together, we worked together, and this resulted in a low dose head-to-feet biplanar X-ray system that allowed 3D reconstruction from this simple pair of 2D images. And this is very pleasant for the researcher to see some of the research go to clinic, because now EOS exists in more than 600 places in 40 countries, and it allows to build the spine in 3D, so to have a completely new view on the spine. See, for example, as mechanical engineers, you see here the spine in lying position with the scan. You don't see this, which is when you submit the spine to gravitational loads, you have a catastrophe that is preparing here. And so it allowed really to observe a new view on the spine, and not only on the spine, from the head to the feet. And this is a tool for patient care primarily, but this is also wonderful for basic research and also for building large-scale databases in order to go to subject-specific models. We did a lot of work on going from the pair of X-rays to the finite element model of various regions, lumbar spine, pelvis, cervical spine, which requires to find solution, particularly to get a hexahedral mesh that fulfills quality criteria, and this requires using various mesh deformation techniques, mesh regularization, and so on. Some of the solutions are very efficient, but very long, and we have to take into account, if we want to go to clinics, that all this has to be very rapid, and now we have solutions that are quasi-instantaneous. So we need also, of course, EOS is not the only way to get 3D shape and to mesh and to build a model. We can use CT scans, we can use MRI more and more with some specific adaptations and so on. So we consider that now the geometry, it's tricky, it's difficult, but there are some solutions. For the material properties, it's not easy. For the bone, using quantitative CT or what is called now opportunistic CTs that are taken for other purposes, you can estimate the Young modulus and the maximum admissible stress as a function of bone mineral density, which is calibrated from Green level, and so you can have some solution. Having soft tissues material properties is still a real issue. You can use inverse methods, and we used it with Lafont 15 years ago. Shear wave ultrasound elastography is a very promising technique, particularly for the intervertebral disc, for muscles also. There are attempts in MRI elastography, not yet fully operational, and indentation and so on. But you have to think for each of the solutions, can it be used in clinics in a routine way? But to understand the phenomena, to model, to have some ground truth that you could use in IA with simplified data, you have to do basic research. And the first step is, how can I get material properties of the tissues? And the loads, having the subject-specific loads, are the most challenging issues. Because here you have an example of instrumented lumbar spine model. You can apply a compressive load, and you can simulate an offset due, for example, to postural trouble. And with this offset, which is less than 6 centimeters, so it's very small, you can have a 500% increase in adjacent disc fibers, maximum normal forces. And we know that one of the real issues in spine surgery and cause of complication is the adjacent disc failure. So there is a relationship between postural trouble and spine overloading, and this can be a reason for complication. You have to model it. And it is complex. Why? Because you have the spine configuration in, for example, erect position or during a movement. You have a very wide range of proprioception, local and global sensors, ligaments, vision, skin, and so on. And these sensors provide information to the neurocontrol system that will process the information, activate the muscles, and the muscles activation will yield muscle forces on the spine, which add to gravitational forces. And one of the reasons for complexity is also that the fact that spine tissues are living tissues, and when you have overstress when you have complete stress release, the bone material properties change, the tissue change due to mechanobiologic phenomena that are probably you heard of that from high specialists of the topic. And going to pragmatic subject-specific modeling is a tricky task. And again, we need basic research. How do we stand? How do we move? And we did a lot of work because we had these full-body biplanar X-rays with the associated 3D reconstruction, and we found an invariant. If you look at the extremity, the tip of the odontoid that we call OD point, it is very close to the head center of mass. There is Professor Vital, who many years ago weighted heads, and a head is 5 kilograms, so it's heavy. And this odontoid we can plot the line going from the odontoid to the hip axis, which is at the middle of the femoral head, and look at the ODHA angle. It's very small, 2 degrees plus or minus 2 degrees. So this is an invariant in many, many situations, and it has been confirmed on more than 1,000 subjects, either asymptomatic or with various pathology, except in extreme case. And so to maintain the head upon the pelvis, you must induce compensation mechanisms that can have very strong clinical implication. And during surgery, if you don't put the head upon the pelvis, the patient will manage to push something to get the head upon the pelvis. And so we have to quantify the load. in the classic way of working, we have to do a subject-specific free body diagram. We cannot use statistic analysis with people because there is a large diversity. And so we built a method, again based on EOS, having the external envelope using density models, which are existing for many years, except for the thorax, where we improved the situation, and computing the barycenter of each of these body segments, because when you have a density model, you can have the mass and center of mass of each body segment, and then finally compute the gravitational load and the gravity line without having any force platform, and then you can do subject-specific free body diagram. Here, for example, you can cut virtually, of course, in slices the external body and compute the center of mass of each part, and then you have the barycenter of the upper body segment with the gravitational load and the lever arms with regard to a given vertebra. And this is particularly important. I will take some time to try to explain you why it is important. Because the impact of the gravitational loads depend on lever arm and also on vertebral position and inclination. And we use it with the finite element model. I think I forgot to put it, the name of Raphael Badawi, who helped me for these simulations. And you can see here, if the load is centered, it's what we expect from the behavior. And if you look at the intervertebral disc fiber forces, they are very low in this situation that we call situation 1. If the load is, for example, deviated here in the lateral direction, but it can be also in the sagittal direction, then if you run the model with the same thing, you see that the loading of the disc is not the same, and that you have some complex motion that occurs. And then if you look at the disc fibers, you see that you have some parts of the disc which are highly stressed. And if in a third situation you have the sagittal tilt of the vertebra and the deviation, then you decompose this gravitational load on the plane of the vertebra, and you realize that you have one component with the lever arm which will yield an axial torque. And you can see here, look at the spinous process, they are aligned here, and when you simulate, you see that you have a small rotation. We can say, okay, it's a very, very small rotation, we can neglect it. But if you look at the stress, now you have high stress in the intervertebral disc, 10 times more than in the normal situation. And this can explain vicious circles. When you have a small postural trouble, then you can have high stresses in the disc, which will deform the disc, and for which you will have a biomechanical cascade that can occur. Fortunately, we have muscles. Their role is to protect the spine. So it's very nice because it allows not to break the bones and the fibers each time you take a heavy charge. But this requires that we model the muscles, and we developed some works on subject-specific loads, muscle control models, looking at going from the principle that the loads has to regulate, the muscles have to regulate the loads that occur on the spine, because if you overstress the spine, you degrade the system. And this is a control model with subject-specific free body diagram. But all this took a lot of time, and we still do not introduce in the model something which is very important, is the muscle alteration. Here you have an MRI of normal muscle distribution, and here for some of the patients that were considered. And Professor Emmanuel Ferrero, who is an orthopedic surgeon, did her PhD on the relationship between the muscles and their quality, their volumes, and postural troubles, and this provides very, very interesting information. And this is basic research, but we know that it has real implications for prevention, for better surgical strategy. If with some instrumentations you have to degrade the muscles, and sometimes you cannot afford degrading muscles that already are not in very good situations. So these are things that can help the surgeon think qualitatively, but think of these muscle issues. It's not only how do we stand, it's also how do we move. And so with the team of Ayman Assi in Lebanon, we did a lot of gait analysis combined with biplanar X-rays, 3D bone reconstructions. You see here that the patient takes X-rays with the markers in place, which allows to have the motion analysis with the subject-specific skeleton, and not only with a scaled skeleton. And we observe very interesting things. Again, this is basic research. We see that the controls and also some of the patients, when they walk, they keep the ODHA angle, so which is now during gait cycle, it keeps quasi-invariant 2 degrees as in static situation. But with people with severe imbalance, they need to push the head forward in order to walk, and so they have a walk which is not economic at all, because permanently they load the spine, activate the muscles, and so on. But we still have years of research to fully understand all that and fully model all that. If we go now to sorry, what can we do with all that? Is there some research that went to the clinic? The EOS system with the geometry went to clinic. And from the EOS, we could build models that could be used for surgery correction of scoliosis, and the work was done in very close collaboration with Jean Dubousset. And you can see here an example of animation that explains the complex motion that occurs during the gestures of surgery planning. We also work with another type of instrumentation with Professor Steib, the in situ contouring technique. And so again, we have to observe very carefully what is done in clinics. You see here the gesture, and with elastic deformation, plastic deformation, elastic return, and you have to model the mechanical phenomena that appear and be able to mimic the contouring technique. We had more than 15 years of teamwork, 5 PhDs, and the proof of concept was done for 30 patients. We demonstrated that we were able to predict the shape that would be reached with a given surgery. This is very useful for basic research to understand what happens, the effect of a given technique strategy, and so on. So we expected that it would go to clinics. The last publication was in 2010, and 15 years ago we still do not have a clinically used application. Why? It's still academic. How to impact patient care and clinical outcome. And today we have nice academic model, but still up to 40% complications for spine surgery. And thinking of all that, I discovered something that is not used in research. It's used technology readiness level is are terms that are used. They were introduced by NASA, and they are now used on innovation, but not in research. You go from TRL1 is when you have the idea, the basic principles, and so on. TRL2, formulated technology, and you go up to TRL4, which is the ugly prototype. We have the very nice ugly prototype. These were engineers that build the model, spend hours to do everything proper, and with that we have the proof of concept, we have the result, which is promising. But then you have, before it can be commercializable, you have to get the prototype in a representative environment and to go for various TRLs. And do you know what we call between the ugly prototype and the first product? This step is called the death valley, because many innovations, you reach that and you say, okay, companies come and take this innovation and push it to the clinics, but the company says, no, it's much too risky at this stage. I have to spend a lot amount of money, and I'm not sure I will commercialize. So no, and once we understood this and passed our frustration and tried to think how to go, finally I decided to co-found a company with partners which are also on business issue, finance issue, and so on, to push that to clinics. And this is the Skyros company, which aim is to build subject-specific biomechanical spine digital twins for support to innovative implant design and for treatment planning. And so we have to pass from academic research to the real needs of clinicians and implant designers. The technology is there. We had to go from a white page to rethink every model with agility, robustness, and so on. And we know that this need is well recognized by the FDA, which support the building of biomechanical models, of generic models for implant design support, population models for in silico clinical trials, and they consider that with the model value maturity, 1/3 of the patients which are need in clinical trials can be used in silico, which means using virtual models. Do you have an idea of the cost of a clinical trial? I have not the response of the room, but it's more than $20 million to evaluate an innovative implant on patients before having the FDA approval. And also FDA supports the patient-specific model when we are able to personalize the model. And this was a short-term challenge for Skyros, and we were laureate of the INOV project, which allows to go in this direction 2 years ago, and we are finishing the 3rd year in some months. And I found this journey. I come from academic. I'm professor of biomechanics, but it was fascinating how I changed my view because in my mind, solving the scientific and technological challenge is 90% of the work. And I discovered that it is only a short piece of the mountain. Models have to be robust, agile, versatile, fully validated, and fully validated doesn't mean just be able to publish. There is a VNV40, probably you heard of it in this summer school, where you have to define very rigorously the condition of use, the quantities of interest, the process of modeling, the risk analysis, how you mitigate the risk, and so on, because you go to the patient. So you cannot just go with a model which is not, which could harm the patient. You have to prove clinical relevance. What is the added value of the model which justifies that the surgeon takes time to use that. So you have to collect data, but you have the general data protection regulation and so on. So all this is a huge amount of money, it's a huge amount of time and money, because you have to build a team, you have to pay salaries to this team. So you go for fundraising. To have fundraising, you have to write business plans, to do pitch deck, to think of cash burn. I learned many new terms. Fortunately, I'm not alone for that, and Aurélien Laville, who is the general director of Skyros, and the other associates take care of this kind of things, in which I was at the beginning completely analphabet. I tried progressively to understand some of the things. But I would like to present an example of the very preliminary proof of concept. Raphaël Badawi did his PhD in collaboration between Skyros, Saint-Vincent de Paul Hospital, and the team of David Mitton in Lyon. And here you have an example of Emmanuel Ferrero, Hôpital Européen HEGP, of a lady that had a screw rod fusion, and she had a proximal disc failure which necessitated a reoperation, and she had the postural trouble. And we modeled the geometry, and we modeled generic load that we have on, let's say, standard patient. Then with the same instrumentation, we modeled the subject-specific geometry of this lady with standard load, and then we modeled the subject-specific geometry with subject-specific loads resulting from her postural troubles. And here you have the example of the results of the adjacent disc forces. In the reference model, you have these force values. Because the geometry of the patient was not so classical, you have this value of maximal forces in the disc. And because she had a specific geometry and a particular load, then you have a factor of more than 2 for the loads that are applied. And you understand that model can explain the failure that occurred, but only if you take into account subject-specific geometry, subject-specific loads, and we are now in a process of extensive data collection in order to bring this the proof of concept on a larger part. So we can say it's okay. We build the model, we have validation, we will have 100 patients or something like that, and prove the concept. Is it sufficient? Not yet, because you have to embed that in a surgical planning tool. And if the user is a surgeon, it has to be usable by a surgeon. And in many times you say, well, we are engineers, we do the product not only for spine surgery planning, for many applications. And then we'll explain the surgeon how he has to do, and it will be very good for him or her. But the surgeons know what is good and what is not good. And if you don't involve them from the beginning, you may have difficulties. And so we have Maïlis Fu, which is a PhD student working with the NSAM, with the laboratoire, which is specialist in user-centered design in order to think the product in very close collaboration with surgeons, questions of economy, fully automatic image processes. We have another PhD student working on with IA on fully automatic X-ray processes to get the data. It has to be robust, it has to be pedagogic in order to provide results that are intelligible, etc., etc., etc. I will not spoil the story, but I can say now we are very happy because it's coming very soon, this first product which could help to plan the surgery based on finite element model, but we have still a huge amount of work to do. In conclusion, research in clinical biomechanics of the spine is a long, fascinating journey in which there is a real continuum between basic research and clinical issues, because basic research feeds our global reflection, our common reflection between surgeons and engineers, and help us orientate more clinically dedicated issues. Subject-specific models are really promising approaches. They require strong collaboration, clinicians and engineers, and we have to always think of compromise between pragmatism and clinical relevance. If we oversimplify, we'll have results which will not be clinically relevant. If you want to take into account all the details, it still takes years to go to clinics. So it's a real issue to try to find the good compromises. But if we want it to be used in clinic, it has to enter into the clinical flow and use tools that are used in clinical routine. And in this adventure, we are progressively filling the gap to impact the patient outcomes. And personally, this is what drives all my career. And I know that for many young researchers, we want to go in this field because we want to impact the patient's outcome. I think that this is a very good journey, even if you are in the beginning of the journey, but you know that it is a long-term research, and it's a fantastic long-term research. The future. There are still avenues of research based on neuro-musculo-skeletal modeling, not only for surgery planning, also for prevention, early focus, mini-invasive treatment, mechanobiology, in vivo means of exploration. When I was in PhD some years ago, we still used at the beginning of my PhD this kind of card, which are, I was coding in Fortran, and it was one for Fortran line by card. And so it was the Middle Age, even if it was not 500 years ago. Today, in the skeleton, we put this kind of implant, and there are a lot of the concepts of implant, but all this stuff will be seen as the Middle Age. In some years, we are really at the beginning of a revolution using precision medicine with devices that will be with new material, with tissue engineering-based materials, and so on. And for that, we need research. And we, in Skyros, we did a mechanism that I feel could be interesting which is there are some actions of the of Skyros which are devoted to a researcher found for clinical biomechanics of the spines, which means that when the surgeons work with us to progress in the field of subject-specific modeling, when Skyros will have money, for the moment it's not the case, but it will be automatically a part will automatically go to research to build the treatments of the future. And so finally, I have to acknowledge all the academic, clinical, and industrial partners, the volunteers and patients who allowed to reach these results. My mentors, François Lavas and Jean Dubousset, one engineer and one clinician who fed me with a lot of issues. Also the engineers, surgeon and PhD students who now contribute to make this dream come true, and many other young and senior talents. And I have to thank you for your attention. I think sometimes for the questions.
Thanks very much for this very impressive and very comprehensive presentation. Do we have questions from the audience? Yes?
So thank you very much for the talk. I think it was very insightful.
Can you speak louder, please?
Okay, I'll try. So I had more kind of a clinical question. Maybe I have to approach, or can you hear me properly? No?
I can hear you, but a little difficultly. Go on.
Hello?
Hello, now I hear very well.
Okay, sorry. So I wanted to ask a more clinical related question, because you mentioned on the beginning that for the alignment of the spine in cases of postural imbalance, the most common procedure is to use pedicle screws and intervertebral rods to bring the spine to a proper shape. However, in our experience with surgeons, we have often encountered that they tell us that pedicle screws and intervertebral rods are not enough, and often they need to perform an osteotomy to reshape the spine and bring it to a new posture, and then put the screws and rods as a way of stabilizing the spine. So I wanted to ask if you have ever encountered this issue, and did you consider including it in your biomechanical models?
Yes, absolutely. This is an important point. In extreme cases, surgeons have no solution that cutting the bones, doing an osteotomy to reshape the spine. And there is a real issue on the osteotomy angle, because if they overcorrect, they will have a spine which is bending backward. And as the patient has to put the head upon the pelvis, you will have what is called the PGK, postoperative junctional kyphosis, and it is one of the major causes of mechanical complication. But if they do not cut enough, then they undercorrect, and again, you don't correct sufficiently the postural trouble, so that is not good. So there is a real balance on what angle should I put for the patient. And we worked on that for many years with the orthopedic surgeons from Bordeaux, from Paris, and so on. And the alignment procedures allow to compute this angle for the realignment, but we have to keep in mind that it helps a lot, but it is not sufficient because you have also to think there are the complications for osteotomies, maybe also rod fractures, maybe pull out, maybe, and so alignment is very important, but it is not sufficient.
Okay, thank you. I don't know if I can ask one more question.
Yeah, go ahead.
I also wanted to ask, you showed a slide where they were doing some intraoperative rod bending to bring the spine to a proper shape. So I guess this intervention was being done with the patient placed horizontally.
Sorry,
So,
could you repeat the last part?
Yeah, the surgical intervention was done with the patient placed horizontally on a bed.
The patient was, the scheme is explained on synthetic bone, but indeed the patient is lying ventrally and the surgeon has to bend the rods. More and more you have patient-specific pre-bended rods, but in many cases you have to, the surgeon has to bend the rod in situ. And sometimes it pre-bends bends it and try then to fit it in the column. But the behavior will depend on the stiffness of the rod and the stiffness of the patient. And this explains that sometimes when you compute a rod bending, post-operatively, you don't get these values because the rod has deformed because the spine is very stiff.
Okay, so my question was if so you take your scan with the patient standing and you build a model on a standing posture, but then the patient is horizontally placed. So could there be an offset that affects so the posture of the spine is not the same horizontally and standing?
Absolutely, yes. This was, I spoke of 10 PhDs working one after the other on the topic. One of the issues was to simulate the standing to lying position, so remove the weight of the head, and so you have to model all the procedure with everything that could impact the results. And so passing from standing X-rays to lying configuration has to be taken into account. Sometimes for adolescent idiopathic scoliosis, they put traction before doing the surgery to reduce the course, and so you have to simulate the traction. So the simulation of the procedure is a tricky part, but it is essential if you want to model properly what happens.
Okay, thank you very much.
Okay, thank you. Any further questions? Yes, we have. Let's try.
Thank you. Do you hear me? Hello? No? Okay, I go to the front.
Is there any other question?
Yeah, no, thank you so much for the talk. It was really interesting. I have a question regarding the rib cage. I saw in some publication that you already found the rib cage midline in biplanar images.
Sorry, could you repeat?
Sorry, I saw in some publications that you already found the midline of the rib cage for biplanar X-rays. And I was wondering if this is also possible for EOS images, or if the hand posture or arm posture is basically in the way to find these midlines for the rib cage.
This EOS imaging did not choose to push that to the routine clinic, and so the rib cage is mainly for research. And going, well, I have two hats now. I was researcher on this 3D reconstruction of the rib cage, of the pelvis, of many things. But now going to what we are currently doing with the aim to go directly to clinics. The rib cage is the second step. Currently, we don't take it into account, but as soon as the first step with the clinical routine use of the finite element modeling goes, the next step will be bring this rib cage stuff to the clinics also, because they can be important to take into account.
So the overall method with finding it on the image, do you think it would be possible to do it, or is it the resolution of the EOS image? Do you think it would allow to find the rib cage?
I think that IA is making a drastic progress. Segmentation from the images also is making drastic progress. So I think that there could be innovative methods. We published with the rib cage stuff some 10 years ago. And I think if I had to redo it today, I would do it slightly differently, but what is important is that we have information on the image. We can build databases that come from X-rays or from CT scans or from any other things to try to get some ground truth and try to have methods recognizing either the midline or the two lines that represent the rib cage. Okay. I don't know if I answer your question.
No, yeah, thank you so much.
Yes.
Okay, thanks very much. Any last question? If not, then for the sake of time, I think we will close the session. Thanks again, Professor Skalli, for the wonderful presentation. Thank you.
Thank you. Thank you for your kind invitation. Well, bye-bye.